You've seen these options. You've seen in this case. What would you choose now for this lady with an anterior vaginal wall prolapse? Did anything change in your treatment options by these three presentations? Those who are now in favor of pessaries, would you please raise your hand for this case? That remains a little bit the same, I think.
The same.
Pelvic floor physiotherapy. Who would start with pelvic floor physiotherapy? Thank you. A traditional vaginal anterior vaginal wall repair. No mesh. With mesh or an abdominal approach? Just one. I think it's more or less
the same. More or less.
Thank you. Then the second case. That was a complex patient who had already had an anterior traditional repair in the anterior vaginal wall. Who would do pessaries with this lady? That's about the same.
No. We have a big increase in the number of attendees that are going for pessary now.
Okay, yeah. Okay. Who would start with pelvic floor physiotherapy? You count them?
We got 7 and now?
About the same.
About the same.
Who would do the standard anterior posterior vaginal wall repair eventually with a hysterectomy or not?
Majority.
That's about the same?
About the same.
And who would do pelvic floor surgery with mesh? Anterior, posterior vaginal wall?
The same.
And finally, who would do an abdominal approach in this case? Okay, thank you very much.
Thank you.
The three presenters, do you have any comment on these questions? Please go behind the microphone. I'm sorry, you cannot sit here.
To me, the most important thing would be how much this bothers her, what does she want, and what are her expectations. And I can't see that in both the cases.
Okay. Are there any questions from the audience? And before you come up, I have one question for Professor Caribeu. Are there any predictive factors by which you can decide upon choosing for physiotherapy or choosing for surgery?
Not from the studies that we have. I don't think we have any understanding of this important question. So we don't know who will respond and who will not respond.
So we still have to investigate that.
Yeah.
Thank you. Please do for the first question.
Thanks for excellent presentations. My name is Anita Harding from Canada. I'm a urogynecologist. I think we probably all in the audience know this and do this, but giving a patient an option of a standard anterior-posterior repair with vaginal hysterectomy still does not address the apical component. And so when we give patients the option, I think some sort of apical suspension, vault suspension, uterus cycle, whatever you want to call it, kind of has to go in that little pocket there. Because if you're just going to do anterior-posterior repair and leave the uterus where it is or leave the vaginal vault where it is, well, guess what? It's just not going to look that great.
Thank you. Yeah, there's one over there.
Dr. Caribou, Elizabeth Dalamo from Barcelona, Spain. If you find a pulmorectalis avulsion by 3D ultrasound, what do you do? And do you change something in the pelvic training?
Well, I think most of the studies have been with cystocele or anterior compartment. So it's we don't have a lot of knowledge on that part.
Thank you.
Yes, yeah. Go ahead.
Any other question from the audience? Yes, please come to microphone.
My question is to Dr. Thacker. This patient has progressed in 17 years. She's got worse. Do you think your ring pessary will really slow down the progress of the disease? And my worry is when she's 87, am I going to be pushed into operate? Well, hopefully I won't. I'll be retired. It's the long term. There's a group of patients who you think this patient's going to have pessary for a long time. Does that alter the way you think about the patients?
Again, I would. That would be something I would discuss with her as well. It is a consideration. Some of them will just not want to have surgery if they've previously had surgery. But if that's what she wants, I would do surgery. On the other hand, if she wants to have a pessary long term, I would offer that to her. What would be most important is that she remembers that that pessary needs to be changed frequently. It's not forgotten like the cases I showed you. I've also seen quite a few cases where when they use pessary for a long time, there's some fibrosis and the prolapse actually gets better. I've seen that more often than I would think about. And there is some evidence in literature as well.
Joanne Sabourin, Canada. Dr. Taka, have you used a combination of pelvic floor therapy with the pessary? Because it seems in my clinical practice that when you use the combination, sometimes to reduce the size of the pessary and maybe.
So everybody who comes to my clinic and has a pessary would be advised about pelvic floor exercises as well. Yeah. So I do give them a leaflet. I may not send them to the physical therapist just because of the restrictions on our practice, but I would advise them that as well.
Michel Jabour, urologist, Beirut, Lebanon. It's about the pessary also. It seems that it's a cultural issue. It's amazing. In my country, you can barely find the pessary in a pharmacy. And to suggest the pessary to a young, sexually active woman, it's almost like a heretic issue. I don't know, how could you advise, how could you suggest something and convince a young, sexually active woman of using a pessary? How could you do that?
Well, first of all, I would tell her all the things I've told you, that it's successful, it would give her temporary improvement. You could even teach her to take the pessary out when she doesn't wish to have it. Involving her in the care is what's going to get you to accept the patient to accept the management. In
your practice, how is it taken by the young patients?
Absolutely fine. I mean, it all depends on what you tell them. And I certainly would try and put them off surgery, especially if they're young, if they haven't born children. And I would tell them that.
Thank you.
I think it has a lot to do with our counseling and also our biases.
Beth Shelley, physical therapist from the U.S., and this is really just mostly a comment and in the discussion of how to choose what to do. I think that I have seen in my own practice, and there's some mention here about making decisions on what to offer patients based on what's covered. And certainly in the United States, we have a lot of limitations on what's covered. But I think that it's very important, just as we are discussing the pros and cons of the surgical procedure, that patients are offered all of the options, regardless of the monetary limitations. Some patients are willing to pay for a treatment like physical therapy, whereas maybe it's covered in other places and that's not an issue. So just a comment that I think medical decision-making and including the patient in that should not be limited by financial constraints. We need to tell them what's available and what the pros and cons are and let them decide. Thank you.
Roger, I'd like to ask you a question. For what subset of patient do you recommend the use of mesh?
So in my hands, the mesh use has decreased because I've been very unhappy with the long-term outcomes with it in terms of erosion. There are still patients, and it's approximately 20 to 30%, I would say, Paulo, who need an interpositional graft, and obviously one choice would be synthetic mesh. I think we also have good biologic choices, and I do use porcine dermis in the appropriately selected patient as well.
And what is the selection for? How do you select the patients for those different meshes?
Well, Harry, first of all, I tell all patients there may be the need for interpositional graft, and that's really going to be an intraoperative decision. If she's had a mesh-related complication, obviously I will not bring mesh forward again, and we'll go with a biologic under those circumstances.
I understand. Thank you.
Can I just make a quick comment, which is something that I haven't actually seen discussed today, which is the level of the activity level of the patient. For me, makes a big difference. So if I have a patient who is extremely active, does a lot of work that requires lifting, even though she could be 70 years old, but she likes to do a lot of outdoors activity that might put her at higher risk for progression of prolapse. My decision on what kind of procedure I choose might be dependent on that. And I bring that into the discussion almost every time. And I just want to mention that.
Thank you very much. That's really welcome advance to this. Mark.
I've got a more philosophical question for you, Roger. What is your opinion? You've got such a wide spectrum of operations possible now. Should, in your opinion, every urogynecologist or even every gynecologist be able to do the whole spectrum of this, or should we even within urogynecology go to super specialization, more the abdominalist versus vaginalist and that sort of things?
I think that we are going to an era where, because of the cost related to our interventions across at least Western Europe and the U.S., that there is a trend now towards super specialization and with individuals who are very, very focused on certain approaches. I think it's very difficult to be good at that entire list of procedures. For instance, I don't do uterosacrals. If I'm doing a vaginal apical repair, and by the way, again, just to underscore the comment that was made from the audience regarding the importance of the apex. The apex is critical, and it truly is the Achilles heel. So I think you have to have at least one vaginal apical repair you're comfortable with, and at least one abdominal repair. Should people not do vaginal surgery? Well, that comes down to a patient's, rather an individual's experience. I will say that, and we have seen this in other aspects of urology, as we've moved towards this adoption of robotics, we are losing the capability to do certain types of cases. And I am concerned that if we just go to abdominal procedures such as robotics, we will lose in the next generation the capabilities to do good vaginal surgery. And good vaginal surgery is still a very important part of gynecology and urogynecology.
Any other questions? If not, thank you very much for being present.
Thank you.